To other news now, the National Council of Provinces yesterday passing the NHI bill, which means technically the only thing stopping it from coming into law is the President, who has to sign it into law. But, there's always a but, several organisations have said they'll go to court to stop the bill from being implemented. The NHI is supposed to allow anyone to use a private health facility. Government would pay back the private sector through an NHI fund. It is, of course, much more complicated than that. Russell Rensburg is the director of the Rural Health Advocacy Project. He joins us now. Russell, good afternoon.
Good afternoon.
And thank you very much for coming in. There are lots of voices in our society who oppose the NHI bill. There's organised business, lots of organised business. There are medical organisations, the medical aid boards. You believe it's a good idea. Why do you believe that?
Look, because I think I think it kind of starts on our constitutional obligations, right? Section 27 of the Constitution includes, obviously, the right to healthcare services, including reproductive health care services. Section 9 of the Constitution also, Part 2, looks at equality and equal enjoyment of rights. Health is a scarce commodity, right? And unfortunately, diseases are unlimited, but access isn't. And I think 30 years into our journey into a democracy, it is time to start looking at our institutional arrangements, particularly around publicly funded healthcare. And then secondly, also start looking at how we reform private healthcare provision. I don't think this bill can do all of those things, but I think we have to start somewhere. And I think this is a good start.
I'm going to resist the urge to argue with you for a moment.
Yeah. No, please do.
Sure. No. I do have some things I want to do. What difference do you think the NHI bill in its current state will make? And I know this is just the beginning. This really creates the fund. Look, what difference do you think it'll make?
Well, if you look at our institutional arrangements for health at the moment, right, even though the Constitution recognizes us as one sovereign country, our implementation arrangements over the last 20 years in particular has really saw us developing almost like 9 different health systems. We don't have one standardized package across all 52 districts. Often provinces interpret what they provide or what they provide is shaped by the infrastructure they already have or the populations that they address. So sometimes as an accident of birth, it would really depend on what kind of healthcare services you need. The Minister also, in Chapter 3 of the current National Health Act, was required to sort of declare the scope of primary healthcare services, as well as defining what are essential health services that the state must provide. That hasn't happened. So I think all of these things are resulting into a system that we really can't afford, that we can't measure, and often is very inefficient. So I think with the introduction of the National Health Insurance Fund, we have now an opportunity to standardize some of these packages, right? That will, firstly, in the public sector, and then secondly, those will also aid in regulating the 87-odd medical schemes that we have into offering some kind of compatible package. And we know what the problems were with that particular system in the health market inquiry.
There's also, and I think this is important, we must aspire to something. The Constitutional Court actually talks about, the Constitution talks about aspiration. What for you, what kind of healthcare system should we have? Would it be a healthcare system where everyone goes to the same place? Everyone wants to go to the same place, maybe. What should we aspire to?
Look, I think at first instance we have to make sure that, at least on a population health level, we have access to the healthcare services that we need to enable a good and functional life. Right? So when you look at this United Nations declaration around universal health coverage, they don't look at universal health care. They look at universal health coverage and the different dimensions. And what they're looking at there are things like reproductive and maternal child health services, right? Getting them to a level where coverage is effective. In South Africa, we've done relatively well, but maternal mortality is still amongst very high, depending on which district you're in, and sometimes we don't respond in a proactive way. So it's really about getting coverage levels up, and we've got some research there. For instance, the District Health Barometer published a UHC index showing our progress on some of these things. So overall, in 2019, the country scored 67%, including the Western Cape, who weren't really that far off from the rest of the country when it came to essential health services, right? Infectious diseases, we've done relatively well with HIV, less so with TB, and then there's this new big thing of non-communicable diseases that we haven't even really begun to figure out what kind of service offering we need to be able to address that at a population level. For diabetes, for instance, we have over 5 million people potentially living with diabetes, but only 1 million on treatment, right? So over 4 million people are uncontrolled diabetics at the moment, and that could potentially overshoot TB as the leading cause of death in South Africa.
Actually, strangely easier to live with HIV than it is with diabetes.
Indeed.
Which is astonishing. Okay, Now we go into a different mode,
Yes.
some of the arguments. Just before we get to the private sector and everything that they say, and they'll speak for themselves in a moment again, but one of the things, you talked about standardization of health, and it seems to me we agreed that we're a unitary country. Everyone should be treated the same. But if we just ignore the private sector for a moment, I'm not convinced that a child born with problems in Northwest that needs urgent help is going to get the same treatment as a child born in the center of Cape Town.
Of course not.
So the reason that I bring this up is you talk about standardization, and that's important. The question is, would we standardize up, or is there a risk that actually through standardization that services for everybody decline?
Look, I think the way this bill is designed is that they decentralize a lot of that.
Yeah.
Right, by the creations of this contracting unit for primary care, which is at the sub-district level. Right, and I think there is some leeway in determining what the health need is in that space.
Yeah.
And I think the important thing is obviously the disease management information system that we get, and how to respond to your threats where you are. And all of this is obviously just on paper. It's something that needs to be built over time. But we have significant capacity in the country to do that. When I think about the private sector, I also think like as non-profit providers, we've just come out of 20 years of a dedicated HIV response. We've got HIV to a point where we've controlled it. But now we've built up capacity in organizations like FITS, RHI, Right to Care, who know these districts and can actually work with the state in strengthening district-level delivery. So I think the first thing, we should have a minimum requirement of all services that we need. Right? We should be able to adapt strategies at the local level to local needs. And obviously, someone living in the Northwest has very different social conditions to someone living in Cape Town. Right? So obviously, health follows the social gradient. And often poorer people are less likely to seek health care. And the goal there may need us to be able to go out more and engage people around their health rather than just waiting passively for people to come to the health sector. So it's not the same everywhere, but at the very least, there should be essential services of similar quality that's measured in the same way, and that over time, we can actually give life to that idea of progressive realization. At the moment, how do we measure progressive realization as implied in the Constitution?
It seems to me one of the best arguments against the NHI, and, you know, business always says, and people who oppose it always say, no, we all want universal health care, and then they give you a million reasons. I mean, I think that makes sense. But we're in a very cynical country in a very cynical time. And, you know, Tembisa Hospital, for example, the CEO there, the person who ordered the skinny jeans, still, a year later, there's no final outcome, you know. So the argument would go that we're now going to put billions into an NHI scheme, and what's going to happen to the money, because we know what happens to the money in public health care scheme, in public health care already. The Gauteng Health Department is always in the news for this. So the question then becomes, and I think this is a major issue with the NHI bill, is I think people who may support you actually maybe don't, simply because of the time period that we're in.
Look, I think that's totally to be understood, right? But look, health is a struggle that cuts across, right? For business, I would say. When we look at the business, the recent survey from the Bureau of Economic Research that looked at income levels in South Africa, something that was startling for me was 75% of working people in South Africa earn less than 6,000 rand.
Yeah.
Right? What medical aid can they afford? Right? The public system, the way that it's organized at the moment, is not responsive to their healthcare needs. And if I'm working at ShopRite and I'm working shifts, I can't go to a clinic to see a doctor. We don't have a mechanism at the moment to contract in private providers to serve that population. And I think it should be in business interest to try and support that. Where I understand the risks to business, and I think a lot of it is around Section 33 of the bill, which looks at the future of medical schemes, right? And the future of medical schemes has an impact on how we as the elites access healthcare, right? And I do think that's something that people need to sit around the table and understand a little bit better, right? But we have to put the facts on the table that ultimately we have to look at the whole country. And for us as rural communities in particular, I think rural communities, we want a little bit more decentralization. We want to be able to have the ability to design a healthcare response relative to the needs where we are. And I think for business as well, and for our country's growth going forward, we need some kind of package. You remember from Tembisa Hospital, one of the gig workers, just before COVID, a guy that worked in media, right? Died. He didn't have medical aid, right? But he was so resistant to publicly funded healthcare that all of that contributing factors actually led to a horrible death. But there are millions of workers like that are not protected. So we need to find a way that works for everybody. And I think this is a point in our history when we need to start finding ways on things that we agree and collectively build public trust. And I think what the NHI does by having a phased rollout, focusing on district health services first, looking at how we manage our public assets in hospitals better, will contribute to better health overall. But it requires everybody on board for this thing to deliver in 20 or 30 years, the goals that we set out for it today.
In countries that have done this, and look, let's be clear, in many countries where you've tried to reform the healthcare system, the rich want to cling on to what they have, and they're very careful about it. And health and education are two of those things. Very personal, right? And you see it everywhere. In Britain, even now, they brought in an NHI after the Second World War, 1946. Even now, people talk about how traumatic that was. And what I'm trying to get to is, the NHI bill that we're arguing about at the moment is just the first step for what you would like to see, as you say, 30 years probably.
Yeah, that's a long range. But you'll see what's happening in the UK now, for instance. They have a national health service, and they're going the other way.
Yeah.
Right? So now they have private providers coming in, and I think I'll guarantee you 10 years from now, you'll have the same kind of inequities, where people jump the queue through private provision, rather than sort of wait in line like they do in Canada, where there's no private system. But South Africa is particularly unique. Right? I think no other country in the world had 200 years of racial segregation.
Sure. Inequality is
and underdevelopment. And all of those things have an impact on how services are accessed and delivered. And I think we have to contextualize that and see how we build the story going forward. We can draw from international experiences, but I think our opportunities here are very unique, and we have to adapt and adjust. And improving the governance is actually depoliticizing health. And I think the NHI fund is a step towards making health an institution of state, rather than the whim of a provincial MEC who decides which contracts to award. So there is an upside. It's hard to see at the moment because overall, over the last 5 years, I think the government hasn't really covered itself in glory.
Russell, I think everyone watching, I want to believe you. I want you to be right. Okay, I really do.
Yeah.
So what the bill, as I understand it, doesn't do is it doesn't actually increase health capacity. It doesn't mean that there'll be more beds. If we just use beds as an example. And isn't that, so wouldn't it be better, would go the argument, to basically sort out the public healthcare system first?
But isn't that what it does, Stephen?
Does it?
Right. Look, the CUPs are public hospitals.
Yeah.
Right? The central hospitals that they're looking to provide semi-autonomy to, with their own budgets and their own direction, is an attempt at fixing the public service. I think nothing other than Section 33 of the bill speaks to the private sector. What it also does, it creates an opportunity for the state to contract in, something that under current legislation it can't. We saw in COVID, for instance, how difficult it was to contract private hospitals. And that was a lot to do with the current institutional arrangements. Right? At the moment, we can't contract in. Even the notion in a failed NHI pilots or health system strengthening story is we didn't even have a mechanism to properly contract in private GPs. So we didn't see the value. So I think these institutional arrangements work towards, firstly, it's built on strengthening the public sector, and in the long run, work us towards having a unified system where the private sector and the public sector can work together in a health emergency, which they weren't able to do in COVID.
I think it was competition regulations that stopped them during COVID. But, it's part of it, yes.
It's part of it, yeah.
Russell Rensburg, good to hear from you. Good to hear your arguments. Thank you very much indeed. We're due to argue against someone who opposes you. Don't worry, I'll argue for you in just a moment.
Thank you, Steve.
Russell Rensburg is Director of the Rural Health Advocacy Project.